Hi, Kayla. How
Hello.
are you?
Good. How are you?
I'm great. I'm great. Thank you so
Good.
much for doing this. I think we're pretty much right on time. So, why don't I let you kind of get started and let's get right to it.
Okay, sounds good. So, for those of you who aren't familiar with me, I just wanted to introduce myself really quickly. So my name's Kayla Smock. I'm the president and founder of the Occipital Neuralgia Foundation. So I've been dealing with ON myself for about 6 years now, and that's kind of what pushed me to creating this organization. The Occipital Neuralgia Foundation, we've been incorporated for a little over a year now, so it's really exciting. Um, And then today we're here with Dr. Ziv Peled. So Dr. Peled is a board certified plastic and peripheral nerve surgeon who has a great deal of experience with occipital neuralgia. So before we jump into things, we would just like to preface that throughout this Instagram Live, we'll be sharing information about ON, but we are not in any way recommending specific treatments. That's, of course, a decision that should be made between you and your physician. So, Dr. Peled, do you mind just telling us a little bit about yourself, a little bit about your background?
Yeah. So first of all, thank you for the kind introduction. Thank you again for this opportunity. We had some technical difficulties the first time, so hopefully, second time's a charm here. And first of all, I want to also say congratulations on this ON Foundation. The run this past weekend was amazing, and hopefully you raised a lot of money for a very worthy cause. Obviously, something that I have a deep interest in, and something that's an important part of my life and my practice. So thank you for all that you do, and congrats on your success and setting this up. I mean, I think it's incredible. I know how old you are. We've spoken at one point about that. I wasn't doing anything like what you're doing at your age. Yeah.
Thank you.
As far as my background, as you said, I'm a plastic surgeon by training. I finished my plastic surgery training at Harvard. But then when I was trying to figure out what I would do with my plastic surgery training, I happened upon this whole concept in this very young field, relatively speaking, of peripheral nerve surgery, and that has become a huge part of my practice. It's about 90% of the cases that I see and the patients that I see. And over the last, gosh, I did my first case a little over 10 years ago. Over the past decade, occipital neuralgia and headache treatment has become the biggest component of my peripheral nerve practice. And so each year we see probably a couple hundred patients who have suffered from all sorts of neuralgia, as well as hundreds of other patients with other nerve problems throughout their body.
Mhm.
And we try to help them as best we can.
Well, we really appreciate all of the work you do for the Owen community.
Well, thank you very much. Really appreciate it. Really an honor and it's a pleasure. I will say that out of all the things that I did and, the year of peripheral nerve fellowship training, if you will, that I did after I finished my time in Boston, was at the beginning of that some of the most rewarding, certainly educational experiences that I've had. And I will say that we've had a bunch of nice aesthetic results over the years, and we still do some aesthetic surgery, and those patients are happy, and that's great. And we have
Hmm.
had all sorts of patients when I was first doing a lot of trauma call who've lost fingers and toes, and we were replanting things and doing microsurgery that way
Oh,
and fixing
wow.
fractures and doing flaps to cover bad wounds, and those patients are happy. But I will say, out of my entire practice, which I think is one of the main reasons that peripheral nerve surgery has become such a large component of my overall practice, is because without a doubt, the peripheral nerve patients are the most grateful, because it's really something to take someone that is suffering pretty profoundly and to provide them in some manner some significant relief, and you watch the changes that occur in their lives. It's really nothing like that, and that's really
Right.
so.
That's beautiful. Yeah.
Thanks.
So let's start from the very beginning. Can you just go over a little bit what really is occipital neuralgia and how would you differentiate ON from headache and migraine?
Right. So those are very important questions. So first of all, let's define what occipital neuralgia is. Occipital just refers to the back of the head area. That's called the occipital region of your skull or your scalp. And neuralgia is a term that literally just means nerve pain. So the question with regards to occipital neuralgia really has to do, in my mind, with which nerve or nerve is causing the algia or the pain. Uh, it is a neurologic condition And what's interesting is that because occipital neuralgia causes head pain, many people kind of lump it in, including many physicians, with any other type of bad headache. Now, migraines are also a very severe and significant neurologic condition. They're more than just a simple headache like we all have from time to time from stress and tension and so forth.
Right.
And in my mind, I think the problem that we have when we diagnose patients, and when I say we, I mean the medical community as a whole, surgeons, neurologists, primary care physicians, headache specialists, pain management physicians, whatever. A lot of people who have very severe headaches are just told that they have migraines. And that may or may not be true, but I think in my mind, for the audience that's listening, the key to distinguish between the two is in what the causative agents are. And what I mean by that is a very simplistic distinction. So in my mind, a migraine headache, a true migraine, is actually caused by a chemical abnormality inside the central nervous system, whether it's in the brain, as is most likely the case, or sometimes just in the spinal cord around where the nerve roots kind of come out. And it's a problem that very effectively can be treated with medications and adjunctive treatments like physical therapy and biofeedback and acupuncture. But because it is a chemical problem, not unlike diabetes, chemical agents such as medications are often very effective at treating those. And I make the distinction between migraines and occipital neuralgia, both of which can cause kind of headaches and head pain, because occipital neuralgia, from a causative standpoint, is caused by a mechanical compression on a nerve, whether it's a spastic muscle that is squeezing the nerve, a pulsatile and abnormally large or abnormally positioned blood vessel that is constantly hitting the nerve, or whether you have scar tissue that is preventing those nerves from gliding back and forth as they pass through all the structures of the head and neck, and then as you move your head and neck from side to side and up and down. And that can occur, for example, very commonly from a whiplash type of injury. And so if you have a mechanical compression, something literally physically pressing on a nerve and causing symptoms, then many times the medications that we use to treat migraines or chemical abnormalities are ineffective. And that's something that we see almost universally in our patients who have been many times misdiagnosed as having migraines for years and have been on and off a whole slew of medications, usually with pretty minimal efficacy. And so in my mind, that's how I would define occipital neuralgia. And trigeminal neuralgia is very similar. It's a mechanical compression, in this case, classic trigeminal neuralgia from a blood vessel on the trigeminal ganglion, which is the main nerve inside the brain. And it can be treated in a different way, in that case with surgery inside the brain for classic trigeminal neuralgia, in the same way for occipital neuralgia. So.
Right. Okay. So do you, in your experience, is trigeminal neuralgia and occipital neuralgia often linked?
Yeah, so that's a great question. And the answer is yes, they are often linked. And the reason tends to be a fairly complex anatomic explanation. But suffice it to say, if you were to Google a nerve, let's say the greater occipital nerve, and you saw kind of usually a yellow line going in a certain direction in the back of the head, that's what most people think of when they think of a nerve. But the reality is the nerve cells itself that are the components of that nerve, the neurons, the cell bodies for those nerves are actually either just inside the spinal cord or the brainstem if it's high enough, or just outside the spinal cord and in the brainstem. So think of that as like the brain, whereas the nerve that you're looking at in the picture is like your arm, okay? The cell bodies for the trigeminal nerves are often right next to the cell bodies for the occipital nerves in the central nervous system. And so when you have infection of an occipital nerve, let's say at your arm, so let's say you were to develop an infection from a cut that got infected in your forearm, if it was left untreated, that infection would spread throughout your body and you'd have fevers and night sweats, not just warmth at your forearm where the cut was, but throughout your whole body.
Right.
And in the same way, you have a compression of a nerve at the arm, let's say here at the base of the skull, that whole neuron or set of neurons that comprise that nerve are going to be irritated and inflamed. And if that inflammation and irritation is allowed to go essentially suboptimally treated for a long enough period of time, it's kind of like a forest fire that jumps the clearing that the forest rangers will put in the side of the mountain, because the forest fire on this side of the mountain has been allowed to burn long enough. Eventually the wind will carry the embers to this side and this side of the forest catches on fire. Similarly, if the the occipital nerves are allowed to be inflamed for a long enough period of time, the cell bodies for those will eventually cause some irritation and talk to the adjacent cell bodies of the trigeminal nerves, and you will get referred pain in the frontotemporal region, so in the temple and the front of the face, which are branches of the trigeminal nerve, and you will have symptoms that mimic classic trigeminal neuralgia. And oftentimes these things occur together because as you had in your really nice study, actually, the survey study that you did of your patients, the average time to accurate diagnosis was several years, as I recall. It was like 3 or 4 years.
Almost 4 years.
Yeah, so if you have infections that are allowed to fester for even 3 or 4 days without treatment, you'll get a systemic problem, not just an infection in the skin. In the same way, if you have an irritated nerve that's allowed to go unchecked and untreated optimally for a very long period of time, you will have other sequelae of that, and they are usually connected. So I hope that makes sense.
Yeah, no, that was a great explanation. The fire, that totally makes sense.
Yeah.
So then going back to occipital neuralgia, what would be some of the symptoms?
Right. So the classic symptoms of occipital neuralgia are what we would term lancinating or lightning-like paroxysmal, kind of on and off like lightning and thunder. They don't light up and stay lit up. It kind of comes on and off. But this lancinating pain that usually occurs in the back of the head in the classic distribution of one or more of these occipital nerves. So for example, if you had greater occipital neuralgia, the classic presentation of that would be kind of a sharp, stabbing, lightning-like pain that goes in the distribution of the greater occipital nerve from somewhere around the base of the skull where the neck meets the base of the skull, heading over the vertex of the skull, which means this part of your scalp where I have a nice little bald spot. Lesser occipital neuralgia tends to be off to the side a little bit and kind of tends to come over to the this area above the ear. And third occipital neuralgia would be a little further down the neck, kind of heading up to the base of the skull, but not really classically over the top. Now, that being said, just like every person is an individual, not everyone will experience the symptoms of occipital neuralgia in exactly the same way, because at the end of the day, the idea of pain or numbness or tingling or tickling, it's really a subjective phenomenon. So just because someone doesn't have this lightning-like pain does not mean that the diagnosis of occipital neuralgia is incorrect. There are people who have a significant pressure-like discomfort in the back of the head. There are people that have a squeezing type of sensation. Some people have it bilaterally, which means on both sides. Some people have it just on one side. Some people do have it on and off, but occurring with a great enough frequency so that all the medicines in the world aren't able to really control their symptoms. It helps sometimes, but not others. And some people have pain 24/7 with varying degrees. In other words, they're almost never pain-free if you really drill down and talk to them. But there's certainly times where the pain is, quote, tolerable and the patients rarely notice it, whereas other times it's really just debilitating and, patients are completely disabled. So that is how it classically presents, but the fact of the matter is that the presentation certainly can be quite variable.
Right. Yeah, because everyone's different. So like, let's say someone's watching this video, they haven't yet been diagnosed, but their medical history and their symptoms, everything seems to align with that of ON. How would they go about receiving a diagnosis?
Yeah, so again, a great question. The first thing is, I think at some point you should have seen a neurologist because you want to make sure that you're not dealing with anything more severe, and obviously not to make light of occipital neuralgia. It's a very painful condition. But when I
Mm-hmm.
say severe, for example, chronic or horrendous head pain, could be an aneurysm inside the brain. It could be a brain tumor. And obviously, you want to rule those things out before you consider surgery on a nerve in the neck. So most patients that I see will have seen a neurologist, which I think is a very good first step, board certified neurologist. And you want to make sure as part of that treatment plan that you rule out other potential more urgent causes of chronic headache pain. Then you want to make sure that you've had at least a trial of some different kinds of medicines because it may be something that is chemically mediated. And certainly if you can take a pill with few side effects that is really good at managing your symptoms, well, then that's certainly, even as a surgeon, I'm the one telling you this, I would do that as opposed to having an operation myself.
Mm-hmm.
But most of the patients that I see, and unfortunately there are millions of people every year that fall into this category, have failed multiple medications for multiple medication classes. So, the
Mm-hmm.
people, laundry lists and pages of all the medicines they've tried. You want to have had at least some attempt at using some kind of conservative modalities such as physical therapy, massage, acupuncture, biofeedback. Ideally, as part of the neurological workup, you've had imaging studies, usually an MRI or possibly a CAT scan of the brain or spinal cord, again, to make sure that you don't have an aneurysm, a brain tumor, you haven't had a stroke we didn't know about, or multiple
Mm-hmm.
sclerosis, herniated disc pressing on a nerve root in the neck that could be causing your symptoms.
Mm-hmm.
If you have done all that and everybody's still throwing up their hands and just throwing more and more, usually opiates at you, then you by exclusion could have, for example, occipital neuralgia causing your symptoms. So that would be diagnosis or criteria one, a good history for a peripheral
Mm-hmm.
nerve causing problem. The second diagnosis would be, the second criteria would be a good physical exam that suggests you have the problem. And so about half an hour before we started this, I saw a young lady here from about 45 minutes away, and you cannot touch the left back side of her head because as soon as you do that, she gets these pins and needles and tingling, and she has nice long hair. She can't put it up in a ponytail. She cries every time she washes her hair because it's really the hot water, the cold water, the neutral temperature water, all is painful. And she gets these classic zinging, shooting pains in that area. Plus, every time you just gently tap over where these occipital nerves are known to potentially get pinched, the pain gets worse. So if you have a good
Mm-hmm.
physical, suggest this is a peripheral nerve problem. That would be criteria two. And then criteria three is you have to have a good result with a nerve block. So a nerve block is just an injection of local anesthetic. You don't need to use steroids in my hands because the nerve blocks are not treatment modalities. They will not fix you. The nerve blocks are diagnostic modalities. So they are to
Okay.
be thought of like an MRI. If you blow out your knee skiing and you get an MRI and it shows that, Kayla, you have a torn ACL, the MRI does not fix your ACL. But it'll tell the orthopedic surgeon, Kayla tore her ACL. She didn't tear her meniscus. She didn't fracture her tibia. Here's the problem. Here's the surgery we need to do. Here's what rehab looks like, so on and so forth. And so the nerve blocks work exactly the same way. And this particular lady came in at an 8 out of 10 pain, and we numbed one nerve, the left greater occipital nerve, and the pain went down to a 3. And we
Wow.
then numbed the left third occipital nerve, and the pain went down to a 1, but the remaining stuff was still kind of here on the side. We numbed the lesser occipital nerve, and the pain was completely gone. And that's something that
Wow.
she gets with nerve blocks. None of the medicines that she's tried over the last 5 years have helped. And so what have we done in that case? We've chemically and temporarily inactivated a couple of nerves. And when you have that dramatically positive of a result, you have a good history, a good physical exam, and a good result with a nerve block, that's a patient that has a really high chance of a permanent solution or a permanent decrease in the frequency, severity, and or duration of their pain with surgery. And about 1 out of 3 patients, from a permanent standpoint, can have complete resolution of their symptoms altogether.
Okay. So, let's say they try the more conservative treatments that you just mentioned, like physical therapy, acupuncture, things like that. At what point should they consider decompression surgery? And could you just talk a little bit more about what exactly decompression surgery is?
I think that it's ultimately an individual choice. In other words, when it comes to pain, how much of it can you stand or should you stand is really a value judgment. In other words, it's only the patient themselves that should be able to make that determination.
Mm-hmm.
So if your pain is manageable and you still have other things that you want to try, there's almost always some other medicine you could try, a different kind of physical therapy that someone might suggest. And I think, again, as long as you are determining for yourself that you're able to function, whatever that means for you, and still try these other things, I think that's always reasonable to do. What I advise my patients and what I try to do in my practice when someone comes in, and I think this is true of any treatment modality, whether it's a medication you're trying, a course of physical therapy or surgery, you should have, some discussion with that clinician about at what point will I know if this worked or not. So if you're taking a
Mm-hmm.
medicine, you have to take it for a month, like Prozac in some cases, before you know if it's working or not. You won't have, if you take Prozac, you won't have any effect after 1 dose. Or will
Mm-hmm.
you within 1 or 2 doses if it's working? If it doesn't work, what's next? Do we double the dose? Do we add another medicine on top of that? You should have some kind of plan so that at the end of the day, you're not floundering as many patients are for years and years and years, just kind of trying things on and off. You'll say, hey, I may do medicines for a year. Within a year, we should have found some cocktail of medicines that are either really controlling my symptoms or medicines are not going to work. And same thing with physical therapy. I remember I had I had some knee trouble when I was doing a lot of triathlons in the early 2000s, how old I am. And I went on an orthopedic surgeon. They said, look, I'm not sure what this is. It's probably something we'll need to do surgery for, but let's try a course of physical therapy. And you'll know within 6 weeks if you're getting any better. And if you're not, then we'll go ahead and do surgery. If you are, then you don't need anything. Just keep on with physical therapy. So it's the same thing with that. So I think at the end of the day, it's an individual choice for the patient to make with their clinician. But you always have some endpoint. At what point, doctor, neurologist, will I know whether medicines have worked or not? And then let's talk about the surgery itself. So obviously, when you're talking about many different kinds of nerves and every different combination of nerves, every person is an individual case. Not like an appendectomy where you've got an inflamed appendix. That's the same operation in every single person. The appendix is always on the right lower quadrant of the abdomen. You make the same incisions for every person. You take out the appendix, you close the same way. With occipital neuralgia, for example, everybody has a different set of symptoms. So some people it's just the greater occipital nerve that's involved. Some people it's just the lesser. Some people it's the greater, lesser, and third on one side or both sides. So you have to determine that first. But generally speaking, these operations are done as outpatients. Almost, out of I don't know how many hundreds of these I've done. I think we've admitted 2 patients over the years. And that's because they had such a high opiate requirement before surgery. We knew that they would be difficult to manage pain-wise afterwards, so we kept them in-house to try and titrate that cocktail of meds to control their medicines and their pain. And then they went home. But yeah, the overwhelming majority of patients are done as an outpatient for occipital neuralgia surgery, depending on how many nerves you're working on. The procedure can take anywhere from 1 to 3 hours in my hands. You go home the same day. I don't use drains or any sutures that need to be removed. So usually within 24 to 48 hours, when patients come back to see me in the office, if everything looks good, they are able to go home and I don't need to speak with them and do anything for another 3 weeks or so. And follow up, because many of my patients travel from out of state and out of the country, follow-up is usually done like this via video with telemedicine, which is great that we have these tools these days. Or before that, phone calls, because usually after a successful decompression, it's really just tincture of time. Within a few months, you should know if those nerves are healing and the pain is becoming less and less and less. And there are certainly ups and downs in that recovery process. But hopefully, kind of like the stock market, you know, there are ups and downs, but as long as the trend is this way and the value of whatever stocks you own is going up, you're,
Mm-hmm.
so at the end of the day, you know, the final results, and this I think is true of any nerve operation, carpal tunnel or headache surgery, you really will know about a year after surgery what you're likely to have for the next 20 years. But you can have healing that occurs for many months after a decompression or a transection, cutting of a nerve and burying it in the muscles.
Mm-hmm. Okay. So could you go over a little bit more about success rates and some of the risks associated with the surgery?
Mm-hmm. So there was a really nice, what I consider a landmark study. It was actually published 10 years ago, a little over 10 years ago, February 2011,
Mm-hmm.
by Baum and Guyeron groups at Case Western Reserve in Cleveland. And what he showed, he followed a cohort of his patients for 5 years. And generally speaking, when you have 5-year results, those are considered essentially permanent because it's really hard to follow patients even for 5 years, but certainly for longer than that. But
Mm-hmm.
at 5 years, when all trigger points were adequately treated, and some patients did require a second set of operations, because if you have complete what I call pancranial neuralgia, where everything in the front, the temple, and the back of the head hurts, that is 2 operations by design for me, because doing everything at once is just too much. But when
Mm-hmm.
you have all trigger points adequately treated 5 years after surgery, 88% of patients in that study were reporting at least a 50% reduction in frequency, severity, and or duration, usually a combination of those. And 29% were completely headache-free. And I presented my first 100 cases, gosh, it must be 7 or 8 years ago now, with about a year plus follow-up at the California Society of Plastic Surgeons meeting. And my numbers were about the same. I think 86% of those patients had at least a 50% reduction in frequency, severity, duration. About 36% were headache-free.
Oh, wow.
So those numbers have held steady with a number of different sites that have been published in peer-reviewed literature, you know, within a couple of percentage points. So I think that's kind of the general success rate.
That's interesting how close your numbers were with the other doctors.
Yeah, and I think it speaks to the fact that the numbers are real. I think when you have a
Mm-hmm.
number of places and clinicians doing their own thing, have data that's pretty much the same as what was published by one person, that is probably something that can be repeated with anyone who has enough experience and knows what to do. So, and
Mm-hmm.
that's a good thing. More
Yeah,
surgeons available to treat more people.
right. So then we had several questions wondering if there's cases where your pain could get worse after decompression surgery. Could you just talk a little bit more about that?
Sure, absolutely. And I forgot to answer the last question. Risks of surgery. Okay, so I define the risks of surgery, and this will tie into this last question you asked. There are general risks for any kind of operation. Problem with anesthesia, bleeding, infection. You'll have a little scar in the skin, because anytime you cut through the skin, you're going to have a scar.
Mm-hmm.
And I suppose blood clots in your legs that can go to your lungs. What I tell my patients is most people are relatively healthy otherwise. Migraines alone affect people primarily in the 25 to 55 age group category. So most of these people are generally healthy. Therefore, the problems with anesthesia itself are very, very low. In fact, I've never had anybody have a problem with anesthesia. Bleeding, I've never transfused anybody for any of these operations that I've ever done. So yes, you lose a few drops of blood, but because this is really microneurosurgery, you often lose less blood than you lose when you give a couple tubes of blood for a couple blood tests at the blood bank. Infection, again, just a couple of percentage point chance of that. We've had just a handful of infections over hundreds and hundreds of cases. And usually they're minor skin infections, usually with ingrown hairs from where we shaved a little patch of hair and the hair grew back and you have a small pimple, you pull the hair out, there's a dot of pus that comes out, and you swab the area with alcohol, and it goes away. I've had a few patients that have needed to start a course of oral antibiotics over the years, but I've never had to reoperate on anyone for an infection. And those blood clots in your legs, again, it tends to be a problem when you have a long operation, lie in bed for a week, sort of like we used to do with hip replacements. These operations are outpatients. You walk in, they take a few hours, you walk out. So fortunately, we've never seen anybody back with those kinds of complications. Now, specific to any kind of nerve operation, whether you're talking about carpal tunnel or something like this, theoretically, you could have worse pain, no change, numbness, permanent nerve damage, which is to say permanent numbness if you cut a nerve. And again, you have that discussion with patients ahead of time, because sometimes, depending on the mechanism of injury, and I'll give you 2 examples. I had one guy who had played 14 years as an offensive lineman in the NFL, and his job was to be hit by other 300-pound men many times a day. So his nerves were mess. And we had one other patient that I'll never forget who had somehow survived 6 different IED blasts and 4 tours in Afghanistan and Iraq. So sometimes you get in there and the nerves are really destroyed. And in those cases, you sometimes have to cut those nerves and do something with them so that you don't have a problem later on. And that could result in numbness depending on which nerves you're talking about. And I think actually that is one of the real advantages and strengths of these nerve blocks, because you get a chance to essentially test drive what that could feel like before you have surgery, because the nerve blocks are all temporary. So you could have permanent nerve damage in the form of permanent numbness. I sort of facetiously say our lawyers tell us we have to scare everyone. And so could you have muscle weakness or loss of function? I think it's possible, but all of these nerves that we're talking about, whether we're talking about trigeminal branch neuralgia for the frontotemporal regions or occipital neuralgia, they're all sensory nerves. They don't move any muscles. And when I operate on my patients, I use a nerve stimulator in the operating room so that if I expose a nerve and decompress it, which is always the first step, and you look at it, and it's really, really destroyed, and you think, gosh, I think I need to cut this nerve because this nerve is permanently damaged, I always test that nerve first and make sure that no muscles twitch when I test that nerve, because if they do, that is not the correct nerve and you shouldn't cut it. I have experience, but it's a very easy thing to check in the operating room, so I see no reason not to do that. And so therefore, we've never had a patient who has been unable to move their arm or their neck after surgery. And then, of course, there's always the chance for the need for another operation. Why might that be? Well, if you develop, I suppose, worse pain, if you develop an infection, if you develop bleeding. And in some cases we have, and again, I do this, as you can see, I talk quite a lot. So we have a lot of discussions with our patients about whether or not they ever want me to cut a nerve or not. And there are certain patients who insist that you never cut a nerve no matter what you find, and that's okay. I will always honor my patients' wishes. But what I tell them ahead of time is that if you decompress a nerve and then you tell me not to cut it, I won't cut it. But leaving a decompressed but permanently injured nerve is kind of like doing CPR on someone that died a month ago. You can do all the chest compressions you want, and they're not sort of dead. They're not mostly dead. They're dead, and they're not going to come back to life. When that person wakes up, they're probably going to have similar pain to what they went to sleep with, because we left a permanently injured nerve. And so one of the main indications for repeat surgery is situations in which we've made a decision ahead of time that we're going to leave a nerve, and let's say patients come back and they're like, well, I'm like 40% better, so it's noticeably better, but boy, every time now I get a shot here and you numb the area, it's like 90% better. You know what? Please go back in and cut that nerve and bury it, and then we can. So those are all the, or certainly most of the major potential risks with these operations, and they're all fortunately fairly uncommon.
Okay, right. So like a lot of us, we deal, on top of the head pain, we deal with other symptoms like light and noise sensitivity, eye pain, nausea, dizziness, things like that. Could decompression surgery help to alleviate those other symptoms?
Yeah, so that's an excellent question. A lot of those symptoms are symptoms that are associated with classic migraines, these chemical abnormalities, whatever abnormality is. Those are what we call kind of like the overactive symptoms from a migraine, much like aura, where all of a sudden you're seeing lights and you have sensitivity to sound and you're seeing flashing things all around. A lot of times, the irritation from the occipital nerves, for example, can irritate the nerves that will cause those symptoms. So it is certainly not universally true that if you have auras, and you have actual migraines, and you have occipital neuralgia, that treating the occipital neuralgia will make the aura with the migraines better. But I have certainly seen plenty of cases in my experience where that occurs. And so, it's very interesting because I'll have patients that come in and they will say, look, doc, I've tried every single medicine in the world, and the only thing that helps is, let's say, Imitrex. But, it's still a problem because it's about a 50% chance that it'll work. And I'll take it early in the headache, in the middle of the headache, late in the headache, just flip a coin. Sometimes it works, sometimes it doesn't. For surgery, my pain is significantly better. So I don't reach for the Imitrex 25 times a month. I'm only reaching for it 5 times a month because it's only 5 times a month that the headache still gets better. So that's like an 80% decrease in frequency alone. But what's really interesting, doc, is that every time I take the Imitrex now, within an hour, the headache is gone. And I don't understand it. How did the surgery make the medicines more effective? And the answer is because you actually have 2 problems. You have occipital neuralgia, something physically pressing on the nerves. You also have migraines. Now, before you had the surgery, you reach for whatever you can, and the only thing that ever worked is the Imitrex. But sometimes, because when you have pain, you take the Imitrex, but if it was the mechanical compression that was bringing on the headache that day, the headache didn't get better. If it happened to be the certain chemical, in this case serotonin, that was off kilter, and you take the Imitrex, your headache does get better. Post-surgery, we've removed that mechanical stimulus. So the number of headaches is gone way down, 80% better. And when you do get a headache, probably this chemical issue. And so you take the Imitrex, and lo and behold, it works every time because that's the only thing that's left. And so you have a problem that has gone from completely debilitating to very manageable. It's not perfect. You still have to take medicine. And that's why I think it's really ultimately important that this is likely a multidisciplinary treatment, chronic headaches. It's not necessarily surgery that's going to fix everything that ails you. We still need to work with our neurology colleagues because people still need medicine, but hopefully at a much lower dose, at a much lower frequency, and with much greater efficacy, because we've removed one of the things that's causing the problem, leaving the medicines to take care of the actual chemical problem, which is what they're designed to do. So
that's very interesting. So going back to like the chemical imbalances and everything, I know a lot of girls, a lot of women, their pain gets worse around their cycle. Could you explain why that happens?
Yeah, so the simple answer is we don't really know for sure, okay? But what we do happens with certain times within the cycle, the menstrual cycle, is that hormone levels of progesterone and estrogen change. And along with that, you have vasodilatation and vasoconstriction of the blood vessels in your body, throughout the body. Now, most nerves, whether it's in the arm, the leg, and certainly in the head and neck, often course along their course with an adjacent blood vessel. Sometimes it's an artery, sometimes it's a vein, sometimes it's both an artery and a vein. And so if you have a nerve that is adjacent to a blood vessel and you have a certain hormone milieu, because it's that time of the month that is causing vasodilatation, then blood vessel is going to be pressing on that adjacent nerve more strongly than at other times of the month where those hormone differences are at different levels, and that blood vessel is relatively vasoconstricted. The other thing that we've learned over the years, and this was shown with the zygomaticotemporal nerves, is that the people who have chronic migraines, in this case, trigeminal branch neuralgia, because the frontotemporal nerves that we treat are branches of the trigeminal nerve. And I use that term because as a physician, I think we need to be as specific as we can be. And so that trigeminal branch neuralgia is different than trigeminal neuralgia, which is compression of that main trigeminal bundle inside the skull. These are here in the scalp and forehead skin. But we know from certain studies of these zygomaticotemporal nerves that people who have trigeminal branch neuralgia or temporal headaches, their nerve structure, when you look at it under the microscope, is abnormal when you compare it to people who have let's say a forehead lift, where you often remove these nerves as part of the forehead lift, and you can biopsy those nerves. So those people don't have any headaches, they're just having a cosmetic operation. But when in this study they looked at those nerves, they looked distinctly different than the nerves in people who had temporal neuralgia. And the conclusion from the authors of that study was that those nerves, as a result of how they looked, were hypersensitized to any trauma such as you would get from an adjacent blood vessel. And so if you have, let's say, occipital or trigeminal branch neuralgia, it is certainly possible that when you have the normal changes in your hormones every month, that the blood vessels are dilating and constricting as they normally do, but that your nerves are hypersensitized to that additional pressure, and you become symptomatic times of the month. Whereas someone who that nerve pathology likely wouldn't notice the difference.
Wow. Okay. Yeah, I mean, so many people, they always say that their pain, I mean, even with like typical migraine or headache, like their pain is always worse around their cycle. That was a really good explanation.
Yeah.
And then we have one final question. So obviously there's a lot of talk regarding COVID and the pandemic and everything going on. So several people have reached out, and their doctors have mentioned that they believe their LN was caused by long COVID. So have you seen a correlation between long COVID causing the onset of LN?
Yeah, so it's interesting that you asked that question. Obviously a very topical subject. So first of all, let's define long COVID. Long COVID is a term used online, and it typically refers to the long-term consequences of a previous COVID infection. So when you're infected acutely with COVID, you have, the fevers, the cough, sometimes shortness of breath, etc. But those symptoms, and thankfully the majority of people, are self-limiting and will resolve on their own within a few weeks. When you have symptoms that persist for greater than 4 weeks, then you have what's called the long-term sequelae or post-acute sequelae of COVID, PASC, or long COVID. So, there have been a number of studies now that we have, a fair bit of experience and some longitudinal experience with COVID patients. There have been a number of patients, even in those who are asymptomatic carriers of COVID, that one of the most common symptoms in people who continue to have symptoms is headache. In fact, there's one study that looked at, I believe, it was 177 or so patients, and 68% of them were complaining of some form of headache as a long-term consequence of their COVID infection, long after the breath, etc., had gone away. First question becomes, well, what the heck's going on? How does COVID cause these headaches? Again, the simple answer is we don't know for sure. We're still learning a lot about this, but there's two potential mechanisms that people think are at play here. One is a direct injury to the little blood vessels that run with the nerves. So if you look at some of the pictures, for example, that I've posted online over the years, one of the ways you know a nerve, once you decompress it, is healthy is that when you decompress it and take the pressure off of it, you should be able to see blood flowing through the little blood vessels that are coursing through the nerves themselves, not adjacent to the nerves, but within the nerves themselves. And that shows you that you have blood supply to the neurons within that nerve, and that nerve might actually recover. When you don't have restoration of blood flow, that is obviously probably a permanently injured nerve. Now, COVID, for lack of a better way of saying it, and in summation, can cause damage to those very, very tiny blood vessels, including some larger blood vessels, and it can therefore cause those neurons to die. So that's kind of like the direct way that COVID can cause an injury to a nerve. It can actually cause the nerve itself to die. The other thing that we think COVID does is one of the ideas behind why COVID is so profoundly awful in some patients, seemingly random, but in some patients, is it causes a massive inflammatory reaction in one versus another. It's almost like an allergic reaction to a bee sting. I've been stung many times over my 50 years on this planet, and it hurts a little bit, but I do fine, and other people can die from bee stings. Their bodies react, and some people's bodies react to COVID by producing, like in a bee sting allergic reaction, a massive inflammatory response, and all sorts of things. Your throat can swell up to the point where you choke. And in in these cases, the nerves themselves basically become compressed, whether it's the nerves that are swelling within these fixed spaces that they usually run through, or whether the adjacent tissues are so swollen that they're pressing on the nerves. That can be an indirect mechanism by which these COVID infections can cause nerve damage. And so, is it possible, if you have a chronic headache as a result of COVID infection 4 months ago, that you have some type of problem that may produce occipital neuralgia? The answer is theoretically yes, because if you have some low level of persistent inflammation, then those nerves are essentially still physically compressed, and then surgery might still help. And we see a nice question here, which I think is related, and I think we can answer fairly quickly. If the nerve dies, would it still respond to nerve blocks? The answer is, if a nerve is truly dead, and it's a sensory nerve, then basically you should be completely numb in that nerve distribution, and you might not have actually any problems. We see this a lot in the diabetic neuropathy population. When people have had diabetic neuropathy, which in diabetes, the nerves are swollen, and when they're compressed for many, many years, those nerves can die, and those people come in and they have had numbness in the bottom of their feet for years and years, and those nerves cannot be saved with decompression. However, most of the time, when that numbness is still associated with not full, complete numbness, but significantly noticeable numbness and pain, that suggests that there may still be life in that nerve, and it's the malfunctioning of that nerve that is causing that pain. And so, yes, in that case, a nerve block should be able to reduce that a little bit. And then, an operation might be able to salvage the nerve by decompression, or you might have to, in certain cases, cut the nerve bearing the muscle, which means numbness, but potentially relief of pain. So again, sorry, a very long-winded answer to your question, but hopefully.
No, but it was a great explanation though, so we appreciate it.
Yeah, of course.
Yeah, so I think we covered all of our questions for tonight.
Okay.
I just wanted to thank you for coming on today, and thank you for taking part in Outrun ON last weekend. Those pictures of you were awesome. If you haven't seen the pictures of Dr. Peled, check out our Instagram. He sent in a couple pictures of him on his run.
Yeah, no, it was fun, and I think, again, kudos to you and your organization for putting that on. I think it's wonderful what you're doing. I'm glad to have taken part.
Awesome, thank you. It was a huge success, the run. So that was our first one. So we're planning on doing it every year. So stay tuned for that.
All right.
So thank you again. Thank you so much.
Yeah, thank you for having me on. Hopefully that was helpful to a lot of people. And again, if you find this helpful, let us know. If you want to do this again, we can, certainly send us more questions, and we'll be happy to answer them at some point in the future in some form. So thanks for your time, Kayla, and thanks everybody for tuning in.
Yeah, of course. All right, thank you.
Bye-bye, everyone.
Bye.